Do you know that perimenopause can last 10 years before the onset of menopause? I'm Dr. Mary Party. I'm joined today by Dr. Natalie Sheeler from Modern Med. We're going to discuss all things hormone replacement therapy, perimenopause, and menopause, and we are very excited for this. Welcome, Dr. Sheeler.
Thank you. I'm excited to be here. I'm excited to have this conversation.
Me too, me too. I was actually doing some research right before we jumped on this, just around women's education around the reproductive cycle and hormones and, sex and reproduction in general. And I was really interested in what I found. There was one observational study that showed that up to 67% of women do not know when ovulation occurs during a menstrual cycle. Is that surprising to you?
I guess yes and no. It's a little disappointing, but I guess not a total surprise.
Yeah, and we see it in practice too. We have a couple of questions on our forms. One of them is, how long is your menstrual cycle? And then the other one is, how long is your period? And oftentimes, like those get confused, and people think their menstrual cycle entirely is 5 days, and they're confusing that for their period.
Yeah, definitely see that all the time.
And so I want to kind of jump in to generally the menstrual cycle and what it looks like. So our hormones fluctuate throughout the course of our life, but let's go through the stages before perimenopause, menopause. Take us through kind of the overview, and we're just talking about female reproductive cycle here.
Yeah, so to start kind of big picture to set the background, as a women have kind of three main stages in our reproductive life cycle. So we have that pre-reproductive stage, which is childhood, pre-puberty, before we get our menstrual cycle. And then we move into our reproductive years. And so that's kind of marked by our first period or menarche. And then after that, we move into the post-reproductive years, and that's marked by menopause, um, which is that absence of period for 1 year. And so I do have some visuals that we could jump into to kind of help set the scene a little bit if I
Let's do
want to
it.
jump in now.
I think it's
Okay,
a
so I'll
really
just
good
share.
place to put some visuals because sometimes it's hard to understand.
Yeah, absolutely. So I'll start here. Can we see that okay?
Yep.
Awesome. So this is what we call the hypothalamic pituitary gonadal axis. And so what that essentially means is we have our hypothalamus. The hypothalamus is a structure inside the brain. And what that does is it releases hormones, one of those hormones being GnRH. GnRH moves to our anterior pituitary gland, which is also up in our head here. And that stimulates the release of two hormones, LH and FSH. These two hormones travel down to our sex organs. For females, it's the ovaries, and they stimulate the production of the sex hormones that we tend to be more familiar with, estrogen and progesterone, or estradiol. That's that main form of estrogen during our reproductive years. And so this is where people are most familiar with, but there's quite the process that happens before here. So it's helpful to see. So it starts up in the brain here, goes to our pituitary gland, and then we get signals to our ovaries to then produce these hormones. And that is helpful to know as we kind of look at what a cycle typically looks like for a menstruating female. And I'll share that image here.
While you're sharing that, I think it's really important. People might want to flip back to that image or Google it themselves when we're talking about menopause and FSH and LH and what happens there. So keep a bookmark there too.
Yeah, absolutely. Um, so then here we see our kind of what the menstrual cycle is during our reproductive years. And so we have kind of two parts to the menstrual cycle, two halves that are separated by ovulation. In this first half of the cycle, we call this the follicular phase. This is as our ovaries start to produce what we call follicles, which are kind of the precursors to the egg that's released during ovulation. So through this first half of the cycle, the follicular phase, those follicles are being produced. Eventually, a single follicle is chosen, and then that gets released midway through the cycle here at ovulation. To helpful to point out is that cycle day 1 here, the first day of our cycle is that first day of our period. This is when we start bleeding. And so usually that lasts around 4 to 7 days. And so we start there. Then once we get to ovulation, that egg is released and the egg starts to produce progesterone. So we see this darker blue line, the progesterone start to rise here. And what happens is, so the body's goal through this process is for sexual reproduction. It is to become pregnant and have a offspring. Not always the person's desire, but that's what's kind of why this is happening in our bodies. And so at this point, the egg here is either fertilized by sperm, and if that happens, then progesterone will continue to get produced, the pregnancy will ensue. If that doesn't happen, that egg starts to break down, and we see that fall in progesterone that you see here. And with that fall in the progesterone, that's the estrogen also falls, and we restart the cycle, come back to day 1, and that's where we have that menstrual bleed here. So that's kind of general overview of what this kind of 28 to 35 day cycle looks like during those reproductive years.
Great. I'm
And
just gonna
then, I'm sorry.
summarize too in terms of
Yeah.
day 1, first day of bleeding. And so oftentimes we'll have women draw blood around day 3 to 5, which means 3 to 5 days after the first day of bleeding. Day 14-ish, of course, like every woman is different. So we're just basing this off a 28-day cycle. That's around where ovulation occurs. That's the number that 67% of women do not know when it happens for them. And then the luteal phase is where we see progesterone being the highest. And if you get pregnant, that progesterone will continue to get produced. Otherwise, both estrogen and progesterone fall. And we've talked about on other videos what happens with that decrease in estrogen and progesterone and symptoms that can occur pre-menstrual as well.
Exactly. Okay, and so keeping that in mind, I'll share my screen of how that changes with as we get into perimenopause and menopause here. Okay, so on this left side of the screen is what we just looked at. These are the kind of pre-menopause during our cycling years. And this looks a little bit different because this is looking at 6 cycles together. So this is one of the cycles we just looked at, the predictable rise and fall of progesterone and estrogen. And then this is another cycle here, another cycle here, another cycle here, etc. So this is over 6 months that we're looking at the 180 days. As we move into that perimenopausal period, the ovaries stop responding to the hormone messengers as they once did. And so progesterone and estrogen production becomes a little bit wonky. And so remember back to that first image that we looked at, we saw that FSH and LH are those messengers that target the ovary to produce those hormones. And so when we see here, if they stop paying attention or they stop responding as well, we get this kind of wonkiness, craziness. And I feel like this is a really helpful image for people to see as they enter that perimenopause time. There can be a lot of kind of crazy symptoms that feel unpredictable and confusing and sometimes chaotic. And I feel this picture can kind of validate what people are experiencing, because this is essentially chaos here. These are kind of hopping all over the place. And then as we move through, we eventually get into that post-menopause after when the ovaries stop responding. And so estrogen and progesterone are both very low. We see them stable here. We still see those FSH and LH messengers from the pituitary gland higher up here.
Yeah, and I love this visual. I actually think we need to show it to patients more often because it does so well visualize what people are feeling. I would say this is probably like late perimenopause too, because perimenopause can be so long. And in the initial, starting menopause, we can talk about what that, or perimenopause, we can talk about what that can look and feel like too. And then you can see in postmenopause, I like that image because you can see how high FSH is, and that's really what we use to tell kind of about where women are in that transition. Yeah.
Yeah, absolutely. Okay.
And so let's go into kind of the next phase in terms of just describing a little bit more in depth what this transition can look like.
Yeah, and so as far as symptoms go,
Yeah, exactly.
yeah,
What are
okay.
women feeling? You know, maybe even like an example of a woman coming in to see you, like what she may report.
Yeah, so we get into that perimenopause is when we start to see changes to the cycle. So a woman might start to see irregular cycles, maybe a missed period or longer time in between cycles. They can start to see changes in their mood and their energy levels. We can also start to see things like hot flashes and night sweats. With time, and changes to libido is another a big one that can occur. And then over time too, we can start to see some other symptoms, maybe vaginal dryness, thinning of some of that vaginal tissue, the vulvar tissue, pain during sex, all common symptoms of that perimenopause to transition menopausal time period.
Yeah. And you might have said this one, but changes in sleep is a really common one, especially in early perimenopausal years. Like even women in like their mid to late 30s can start to experience that. Have you heard that from
Mhm.
some of your patients too?
Yeah, absolutely. And as you mentioned, the perimenopause can start as 10 years prior to menopause. And so that average age of menopause is around 51 right now. And so 45 to 55 is all kind of within that normal range. So that can be as early as late 30s, early 40s that people start to experience those
Yeah. Let's go
changes.
into what do estrogen and progesterone actually do in the body? Because I think that makes the symptoms make sense as well.
Yeah, so estrogen and progesterone both do a lot of things. So this not exhaustive, but kind of what we mainly think about with estrogen. So we talked about producing those follicles that eventually get chosen as a single follicle and released as the egg, responsible for libido, responsible for the building of our uterine lining that gets shed as the period. Estrogen also important for kind of our secondary sex characteristics, things like breast tissue development. Also really important for our bone health. And so a major driver of our bone density there. Um, and then progesterone, I think I covered the importance on there. Anything you would add with estrogen?
No, I think you got it too. Yeah.
Okay. And so then progesterone, mainly we think about it's really important for the process of fertilization of the egg into the uterus, implantation of that egg into your uterus after it's fertilized. It is also helpful for bone support, to a lesser degree than estrogen, but it's also referred to as a calming hormone. It can be relaxing for some.
Yeah. Yeah. Awesome. And when we talk about perimenopause, some of the things that we talk about with our patients is whether or not hormone replacement therapy is appropriate and when we want to start it and that whole discussion. So, first off, what is hormone replacement therapy?
Yeah, so hormone replacement is therapy is essentially using exogenous hormones from outside the body as a therapy. We're typically referring to estrogen, and then we can use progesterone depending if a woman has a uterus or not. And then testosterone could also be included in that, but we're mainly referring to that estrogen plus or minus progesterone plus or minus testosterone. And so HRT or hormone replacement therapy is kind of what we is most commonly talked about or called. Like the official name for that is actually menopausal hormone therapy, but that really hasn't caught on as much as HRT is still kind of more commonly used to talk about it.
Yeah, the lingo is starting to shift, whether it catches on
Mhm.
or not. And then let's talk about the difference between hormone replacement therapy and bioidentical hormone replacement therapy and how there's kind of like this mismatch that's happening there.
Yeah. So first, what bioidentical hormone therapy is the hormones that we're using, the exogenous hormones, the outside hormones that we're using, look identical in structure to the hormones that are found in our body. So estradiol, progesterone, um, estriol. There's different types of estrogen, but they look like the hormones that are found in our body. And so in some, there are both synthetic forms of hormones that you can get depending on where you're located, and also the bioidentical. A lot of the research, which I think we'll talk about, we'll get to, has been done with the synthetic hormones, and there's definitely some safety concerns there. And that has definitely a discussion we can talk about, but those the kind of major differences. Bioidentical look like the hormones we're doing use it that are in our bodies, and then this non-bioidentical are synthetic hormones that can look different.
Yeah, yeah. And technically, are they all synthetic, would you say? Just because, I mean, we're not taking them from your own tissue, right? So they're not your own hormones. We are manufacturing them. But the big difference being that some look exactly like they're exact replicas of the estrogen and progesterone that are circulating, versus we have the conjugated equine estrogens and progestins that look differently to your body.
Hmm. Exactly.
Um, I wanted to talk about, I think I worded it incorrectly. Mismatch is not the best term, but I think that there, a lot of the times I will still get patients saying, I want to make sure the estradiol you're putting me on is bioidentical. Like it's a real sticking point because I think it got a lot of media attention. And for I would say for the better in a lot of senses. However, there's a lot of OBGYNs using bioidentical hormones. So it's not just something that you see in the functional medicine or integrative space anymore at all.
Hmm.
Um, but I'm trying to think of like what my actual question is here. I think my question is the difference between compounding versus commercial pharmacy with these. And so when we talk about bioidentical, it's often associated with those that are manufactured in a compounding pharmacy. So the creams, the things that are made individualized to the person. Versus if you go to CVS and Walgreens, some people think that you can't get bioidentical hormones here. Can you just speak on that point a little bit?
Yeah, yeah. So kind of continuing on what you said is there's that misconception that if you're getting this compounded cream that it's made for you, that's the only bioidentical hormone that's being used. And that if you go to these kind of conventional pharmacies like CVS and Walgreens, that you're getting this, again, word synthetic, even though as we said they all are synthetic in a way, that you're getting these kind of negative or poor hormones that have the higher risk profiles, but that's generally not true. The estrogen forms that are approved by the FDA, so they're available at CVS and Walgreens, are typically estradiol, which is bioidentical. So commonly, if you are going to an OBGYN and getting prescribed something from a pharmacy, you are getting bioidentical hormones. And the same is true for the oral progesterone that's commonly prescribed. That is bioidentical as well. It looks like the one that we find in our body.
Yeah. And that's not to say that OBGYNs aren't prescribing non-bioidentical. They definitely are, especially when they're using oral contraceptive pills, OCPs, to treat perimenopause, which is quite common. And so that would be a case where that would not be bioidentical or body identical. But I think it's a really important point to distinguish. And you and I were talking the other day in terms of when we were in school, a lot of the education was around using compounding pharmacies to get these bioidentical hormones. And there wasn't even a huge knowledge base that was instilled upon us that there were these other forms of bioidentical hormones that are available in commercially, produced pharmacies that are much cheaper for the person, as well as much more regulated in terms of like the dosing being the same for each product. And so we both have, discussed kind of switching away from the creams and the things from the compounding pharmacies to go more commercial for that reason.
Absolutely. And to 10 data of kind of at least what I was taught was mostly surrounding those creams as kind of the best option. But with the kind of more commercial products, there are things like patches that can lead to better absorption. And there's other options there that creams are not always and sometimes aren't at all the best option for patient.
Yeah, great point. What are the benefits? Why would somebody consider hormone replacement therapy? How do you kind of view it and talk to patients when they come in terms of these benefits? And we can go through risks as well.
Yeah, totally. So as far as kind of when somebody's in that perimenopause, menopause time period, um, HRT is the most effective therapy we have for those vasomotor symptoms, which is the hot flashes and the night sweats, and then the genitourinary syndrome of menopause, which is mentioned earlier, the thinning of that tissue, either the vaginal tissue, vulvar tissue, that external genital tissue, vaginal dryness, pain during sex, irritation. And so HRT is the best treatment that we do have for those. It's very effective. So that's commonly what brings up the discussion of whether somebody wants to start HRT. The other really important thing that it does that I think we both kind of agree doesn't get as much attention as it should is the fact as bone health, and estrogen therapy on bone health is very supportive of our bone density and preventative for fractures. And so and low bone density bone fractures are a big deal and can be really serious. I think there's a few studies I can pull up these numbers so I get them right. But
Yeah, please do. 'Cause I think this is like one point where I think I did this when I was younger too. I'm like, "Ugh, osteoporosis, not something I have to worry about. Like bones, no big deal. Like I'll be fine. I'm not going to break a hip," kind of thing. And I feel like it's really dismissed. Well, it's dismissed by me, I should say. I don't know if everybody else is dismissing it. But when you look at the stats, it's like, oh my gosh, we need to be paying really close attention to this, especially because, not especially because, but women, number one, but also women of lower body weight or BMI that are really healthy, who are thinking like, I'm on top of the world, I've got it, I've figured out this health thing. They're at a higher risk than somebody who is obese. And so it is this
Mhm.
thing that happens paradoxically in terms of, having a lower BMI actually increases your risk here, where in most chronic diseases, if you're in a healthy BMI range, it will reduce that.
Yeah, definitely. And just to clarify too, for just that jump there, for osteoporosis, that just means reduction in bone density, that puts you at increased risk for a fracture. And then osteopenia, which is another one, and that's the first stages of osteoporosis. But there was this study, and so they found that older adults have a 5 to 8 fold increase for all-cause mortality or death after that first 3 months after a hip fracture. And then more specifically, white women who have a hip fracture at 80 years old will have an excess annual mortality rate compared to the white women who have not had a fracture at the same age of an increase by 8% at 1 year, 11% at 2 years, 18% at 5 years, and 22% at 10 years after the injury, which is a lot. That's
Crazy.
significant. Yeah.
It's really significant. If you look at the rates for men too, they're very, very high. So this is not
Mhm.
just women, but we're talking about HRT for women here. But 5 to 8 fold increase risk for all cause mortality during the first 3 months after a hip fracture. That's like a
Mhm.
very staggering number.
Yeah. And one of the issues too that you kind of hinted at earlier is that it can be silent until generally the first symptom of osteoporosis is the fracture itself. There's no symptoms beforehand that kind of alert anybody that could be an issue for them. And so we do use screening methods. The DEXA scan, DEXA, is typically what we use. That typically doesn't start till 65 unless there's concern to start it earlier. But yeah, no symptoms before that fracture usually.
Yeah, and I don't know about you, but this is where I do drift off the guidelines here. I think the guidelines are really helpful for a lot of things, but I feel like this one we're going to be missing too many cases if we're waiting that late to test women, especially women of lower BMIs. And so I will test women younger if I'm suspecting that they're at higher risk for
Mhm.
osteopenia or osteoporosis, and I've found it a bunch when I do that. So I think it's worth it.
Yeah. And at minimum, just at least being discussed earlier with women of prevention strategies, HRT being one of those things that should be part of the discussion.
Yeah. Okay. Let's talk about the controversy with hormone replacement therapy. This is actually really nuanced. It's confusing too. There's a lot of misinformation that's out there. And I'll be the first to admit that I'm still sifting through things because there's so much data out there, and some of it is really poorly done research, and then some of it is actually, very helpful. It's all helpful, I should say. However, we need to
Mhm.
we need to make sure that we're reading into it the right way. So give us like a little like overview of the history and we can dive in.
Yeah, so definitely a lot of history, as you said, but um, as far as kind of start us off, in the 1940s, early 1940s, conjugated equine estrogen, or CEE, was first approved for the treatment of menopausal symptoms. That's when we first started having that FDA approval and using them. And then about 30 years later, 30 years after that, we started to see an increase in endometrial cancer
Mhm.
in women who were using HRT. And so that started to raise safety concerns. And so at that point, started using and prescribing progestins, a specific one called medroxyprogesterone acetate. It is a synthetic progestin, so a type of progesterone that binds to the progesterone receptor. And that was used to balance the effects of estrogen. Estrogen can, as we kind of mentioned earlier, is one of its job, promote growth in that uterine lining. And so increased uterine lining thickness raises our risk for endometrial cancer. So progesterone can offset that. So that's when that was brought in. And then that was 70s. And so then in 80s and 90s, we started to have quite a few observational studies that showed that women who were on HRT had better outcomes as far as reduced cognitive decline, better cardiovascular outcomes, and reduced all-cause mortality. And so people started to use HRT as for preventative of those things: cardiovascular health, cognitive health, all-cause mortality, chronic disease. Started using it a lot more frequently there. And that, because there was more prescriptions and more use of those hormones, there's obvious a need for more studies. Observational studies, we can't see cause, so we want those randomized controlled trials. And so in comes a large study called the Women's Health Initiative. And so this is one that some people may be familiar with, because it is often talked about when talking about the risks and benefits of HRT. But so this was that kind of first major randomized controlled trial looking at HRT, and it was about, I want to say 27,000 women, and
So.
they were, yeah, separated into either that CEE, the conjugated equine estrogen, or the estrogen plus the MPA, medroxyprogesterone acetate, if they had a uterus, or a placebo group. And so the outcomes that they were looking at for this study was incidence of breast cancer and then cardiovascular disease. And so what ended up happening is the arm of the study that received both the estrogen and the progestin was stopped early, stopped after about 5 years, because there seemed to be an increase in breast cancer without any benefit on that cardiovascular side or overall improvement in risk for mortality. And so that ended up being stopped. And so then at that point, a lot of concern was raised for the safety of HRT. And there was a lot of providers pulling back on kind of how much they were prescribing, what they were prescribing it for. But I'm sure we'll talk about, there's quite a lot of, I want to say, issues or kind of factors in that study that we should be discussed as far as interpretation of whether breast cancer and and HRT in general is of high concern.
Yeah, and let's do
Um,
that because I don't want people pausing here and taking that all as the takeaway. I think that this trial was really important because there was a lot of off-label prescribing and kind of things based on some information that now we know probably isn't the truth in terms of all the benefits of HRT. But let's go into the Women's Health Initiative in terms of who were the people that they were doing this study on, because I think that's a big part to distinguish is who were the subjects that were actually in this study.
yeah, so they did women, and they did it based on age versus relation to their menopause status. So it was between women who are 50 to 79 years old, and the average age, I want to say, is about 63. So theoretically well after menopause, at that average age of menopause being 51. And with many had cardiovascular history, so there was no exclusion based on that. And so these were older women who could be well after menopause. who potentially had chronic health disease weren't at the best health at the start of the study. And the other thing too is with not screening for by time in relation to menopause, there's also women who were included who may have had a surgical induced menopause earlier, meaning they had both their uterus and their ovaries removed at a younger age potentially, and so theoretically could have gone through menopause if that happened at age 40. And so then they're starting these HRT well after, like 20 some years after they went through menopause.
Yeah, and usually when we're talking about initiating HRT, it's within 10 years of the menopausal transition is the general guideline because of the potential
Mhm.
increased risk. It's not to say that has to be for every single person, but we're really looking at that as the ideal candidate as somebody who is within that 10-year span or in perimenopause even.
Yeah, exactly.
What are some of the other drawbacks of this study that we have to look at?
Yeah, so one of the major things that we look at is kind of the products that they were using. So they were using the conjugated equine estrogens, and that's an oral estrogen. At that time and currently, we do know that if you take estrogen orally, like through a pill, that does increase clotting factors in our blood, increases the risk for clots. The reason we did know this at that time, the reason they used this type of estrogen is because it was the most commonly prescribed estrogen at the time. That's what most of the observational studies was looking at, where we did see that benefit. So they expected that the benefit that we saw with estrogen therapy would outweigh those risks. Now, and we'll certainly kind of circle back to this in the future, but there are other options. And so typically oral estrogen, at least in our practices, is not what we use because of that risk. There are transdermal, it's usually how we're using that. And the other one is the type of progesterone that was used. So it was a progestin and not a progesterone. And so if anything, this study, it was the group that had the estrogen plus the progestin that had the increased risk of breast cancer versus we didn't see that in the group that had estrogen alone. So points to more of the progesterone being problematic than the estrogen itself. And kind of further looking at those numbers. So when we see the study was stopped because there was a relative risk, about 25-26% for the group that was getting both estrogen and progesterone to develop breast cancer compared to the placebo group, which sounds very scary, a 25-26% risk. We don't like to hear that. But that was the relatively risk. If you look at what the actual absolute risk, it only equates to about 0.1% increase in likelihood. And what that means is, so in the group that was the placebo group, there was about 4 women out of every 1,000 who went to develop breast cancer. And in that group who had both the estrogen and the progestin, it was about 5 out of every 1,000 women that went on to develop breast cancer. So that's only one person between the two there. And that is also looking at development of breast cancer. It wasn't not talking about mortality. There's no change in mortality, no change in deaths with that. And so that's something to also kind of think about when you're talking about risks. If there's no change in deaths, do we consider at what risk do we kind of wipe out all of these positive findings for one increased case per 1,000?
Yeah, and that's also given, we have to keep reminding ourselves that they were using conjugated equine estrogen, which I don't think that's the thing. We're talking about the progestin as being the main thing here for breast cancer risk. Not in the ideal set of women either. So there's so many other factors, and yet we were still getting that 0.1% absolute risk increase in that group. So, and that's what halted the entire study to say, hey, it might not be safe anymore. So I think that, and I know a lot of other people are talking about this as well, but we really we were using conjugated equine estrogens then, we're not using them anymore. We need like the same mass study at the same level of participants now using what we are currently using.
Absolutely. And there are some further studies, later studies that looked at the progesterone versus the progestin, and so that and relative risks of developing that breast cancer. And for this one study, it found that the relative risk using a progestin was 1.4, so a 40% increase of the development of breast cancer for the progestin, but a 0.9 relative risk for using the progesterone, micronized progesterone, identical progesterone, which is a 10% reduction in risk of that development. So there are some studies, not to the timeline and extent of the Women's Health Initiative, that points to kind of feeling more comfortable with that safety, but definitely would love more research.
Yeah, yeah. And if you're listening to this on YouTube and you want the citations for these studies we're talking about, head over to our website. We'll have all of them listed at the bottom of the blog there as well. And then let's talk about there. I think there was one additional study. Do you want to mention that one, the Fournier 2007?
Yeah, so then a study that looked on E2, so estradiol and progesterone. And so there was no increased risk on the group who received the estradiol plus progesterone. But in the group that received estradiol and the MPA, the progestin that was in the Women's Health Initiative, they had an increased a relative risk of 1.69, which is 69% increase in that risk of breast cancer. So again, pointing towards that progesterone or progestin specifically being more concerning.
Yeah, so we don't use MPA in our practice at all for this reason, and most other practitioners are obviously um, using the same advice too. Let's talk about other kind of safety contraindications around hormone replacement therapy.
Yeah. So as far as kind of when we want to use it, we've hinted at this already, but we generally recommend starting it within 10 years of the perimenopause menopause time period before 60 years old. And we want to be cautious with people who have established cardiovascular disease as far as safety wise there. The other things that we think about is route with safety. And so if somebody, typically I am not using oral estrogens in most cases, but it is something that is prescribed. You want to be super cautious with if they have cardiovascular history, if they have gallbladder disease, risk for clotting, all of those things we really want to be cautious with because, as we mentioned earlier, the increasing clotting factors.
Yeah, okay. And then let's talk, we've already covered it a little bit, but let's talk about forms in terms of what does it actually look like if you're using hormone replacement therapy? What are you doing on a daily or weekly basis?
Yeah, so it depends on the form that you're using. So the first for estrogen, there's 6 FDA approved estrogen only medications, and they come in different forms. So it can be the oral pill, it can be gels, creams, patches, sometimes sprays. The most common one that we use are patches. And so that looks like using a patch either weekly or every bi-weekly or every 2 weeks. And then switching that as depending on the timeline there. And then if you are using a cream, it's typically daily use, but sometimes people will do 2-3 days a week depending on symptoms and what the absorption looks like for them.
Yeah.
Yeah. And then I guess progesterone wise, so if somebody has the intact uterus, we want to use progesterone. And so there's 2 options there. So the more common one is oral progesterone. The benefit, a theoretical benefit of oral progesterone is there are some systemic benefits. It can be, as we mentioned, helpful for that kind of relaxation. So it can be helpful if somebody takes it before sleep to get some of the systemic benefits there. The other option is that if somebody doesn't tolerate the systemic progesterone, they can use a progesterone-coated IUD. And so that is placed in the uterus that has those local effects of preventing the endometrial thickening, which is what we're hoping to prevent.
Yeah. Okay. And I want to just pose a case to you. So a woman comes in, she is 51. Maybe she just like she hasn't had her period in, 14 months or whatever. she's having hot flashes, she's having trouble sleeping at night. I'm going to throw it all in there. She's lower BMI, so maybe potential increased risk for osteoporosis or osteopenia. What does that conversation look like with her? And then also, if she decides to go on hormone replacement therapy, let's say she comes back in 3 months after you redo her labs, what is she typically reporting? And I know this is fictitious.
Yeah. So to start, first part of the question, that where that conversation starts is, um, if she's bringing up HRT, talking about it from there, if she hasn't, then kind of suggesting it. And a lot of it surrounds education. There is a lot of misconception. And oftentimes I find, I wonder if you do too, kind of in the patient population we see, there is a lot of concern about quote unquote natural or synthetic and the safety there. So kind of talking through a lot of what we talked about today, and some kind of clarification there. And then we talk about her health. We want to make sure that it works for her. And so we talk about those things like the cardiovascular health risk factors. If there's any history of hormonal cancers that she has had, or close family members have had, would want to know about that. Has she had the screening things like a mammogram screen for breast cancer? Is she up to date on her cervical cancer screening, all of those kind of things that we like to do, to make sure that we are doing it safely. And then typically where I start personally is with, if she's not cycling anymore, starting with, and she has, and assumably has a uterus, then typically start with the oral progesterone, start at that lower dose, 100 milligrams. And then with the estrogen, typically recommend starting with the lowest dose estradiol patch, because they tend to be the easiest and best tolerated. And so those are the recommendations. And again, as far as pricing, these are things that you pick up from Walgreens, CVS, your conventional pharmacy. So really, generally, ease of access is good. And then yes, and so then send her on her way. I think I'm covering everything. And then coming back in 3 months or however long, we're hoping to see improvements in those more immediate symptoms that she was mentioning, was the hot flashes, sleep, trying to remember
Mood
everything. And then
changes. She had
mood
everyone.
changes.
Vaginal.
Yeah,
Yeah. Well, we can
yeah,
keep that one out because we're not going to go into it.
yeah,
But
yeah. And so I'll hopefully seeing improvements there. And if not, then we can consider increasing that dose of the patch. And then with time is kind of how we monitor bone density. That is over a longer period of time,
yeah.
more. Yeah.
Yeah, yeah. So she comes in, sees you, order labs, and she'll redo the labs about 3 months before or 3 months after starting the therapy, just to get like a full exposure to the hormones and make sure that she's in a safe range. Progesterone, I dose depending on blood work and symptoms, of course, too, but we're really looking for a adequate blood level of progesterone to protect the endometrial lining. So that's a big factor. But let's just say that one more time, actually, in terms of who gets progesterone and who doesn't necessarily need progesterone.
Yeah, so if you have an intact uterus, meaning your uterus is in your body, it hasn't been removed, um, and it is removed through surgery, so it's not something that you like could have missed. You would have that surgically removed. Then you will receive progesterone. That's because that estrogen supports the growth of the lining of our uterus, which can increase risk for endometrial cancer. Progesterone will balance that estrogen effect to prevent that thickening.
Yeah, yeah. Okay, so she comes back in 3 months. Majority of people at 3 months are going to say my hot flashes, night sweats are better. Maybe they're still there, and that's where you're talking about changing dosing, but usually people will report they feel a lot better with that. Sleep can definitely improve as well. Progesterone can help with that. Mood can sometimes be a factor that they'll say that they just feel better in general. I'm missing
Mhm.
any big ones that people discuss? Skin as well, just like
Sex
skin
drive,
drugs,
yeah,
yeah, sex drive.
big one.
And
Yeah, and
then,
sleep, I think you did say that's the other.
yeah.
hmm
And then we didn't talk about testosterone replacement therapy. We're going to do that in a separate video, but that is part of hormone replacement therapy for women, women actually have more circulating testosterone than they do estrogen. So it's a huge part of how our body functions. And we're just going to save it for another date, but that's part of the discussion when we do have it with women. What are the other things that we maybe skipped over, didn't talk? Anything else come to mind for you?
Yeah, I think it's important to kind of talk about what the change in prescriptions for women with HRT after the WHI because of that
Mm,
concern with cancer. And so I think there a huge reduction. I have the numbers here. So after the WHI was published, the HRT decreased about 80% since then. And so now estrogen's only prescribed to about 3 to 4% of postmenopausal women compared to 25 to 30% before the WHI. And in some ways that's good because we're not using it well after menopause for the prevention of chronic diseases that wasn't effective for. But in some many ways that's not a good thing because women who are in their 40s and 50s aren't getting the benefits with the vasomotor symptoms, the menopausal symptoms, and then quality of life, bone health, missing out on all of that. And so super important. I feel like there's a lot of misconceptions, and that's hurting women and their ability to access
yeah, I think that was
these
really
hormones.
clearly, and yeah, it's so interesting. That's a huge shift. So pre
Mhm.
versus post Women's Health Initiative study, that drastic reduction that's there. Um, Really fascinating and so important that we like keep talking about it to make sure that women get the treatment that they need. Not to say that every woman needs to go on hormone replacement therapy. Would you agree with that?
100% correct.
Yeah.
Yeah, not for everybody, but if that's a decision for patient and provider.
Yeah. Awesome.
Mhm.
Any other nuggets that you have? That was a good one.
Yeah, that was the big one that I have. I think it just highlights the importance of kind of everything we discussed today and making sure that everybody knows all of the information so they can make the decision that works best for them.
Yeah, all of the information, all of their options. There are other ways, obviously, to treat the vasomotor symptoms. So, estrogen is one of the ways, and it is the most successful way, I would say, right? In terms of is
Mhm.
that true? My
Mhm. Yeah, it is the most effective.
most effective way. But there are tons of other options. There's lifestyle factors too that can be really effective. And
Mhm.
so it's not for everybody. Thank you so much for going through all of this. I learned things
Yeah.
on today's call,
Mhm.
which I always do. And we'll be back for another episode at some point.
Awesome. Thanks for having me.
Thanks.